Hello and welcome to Health Professional Radio. Thank you so much for joining us on the program today. I'm your host, Neal Howard. In studio today with us is returning guest Dr. John Popp. He completed medical school at Yale University, completed a fellowship in gastroenterology at Massachusetts General Hospital, and is also former chair of the Division of Digestive Diseases and Nutrition at the University of South Carolina. Joined Janssen as a medical director in the medical affairs department. And he's here today to talk with us about the management and treatment of Crohn's disease and also about some of the unmet needs when it comes to managing and treating Crohn's disease. Welcome to Health Professional Radio.
Thanks for having me, Neal.
You know, when you were here before, we were talking about Crohn's disease, some of the misconceptions about Crohn's disease. When it comes to managing, the treatment and then the further managing of Crohn's disease, possibly throughout one's life, there are sometimes goals or things that just aren't met, things that just don't happen that would be greatly advantageous to the patient and to the healthcare provider if they're recognized and implemented. Talk about some of these needs as they relate to the treatment of Crohn's.
I'd be happy to, Neal. And I practiced for almost 30 years and saw hundreds and hundreds of patients with Crohn's disease. And I think one thing that's very important about Crohn's disease is that it is a chronic disease. We can never look a patient in the eye and say, we have cured your disease. You will never have to worry about this again. We know, for example, that patients who have resected parts of their bowel where the disease has been active and you see nothing but normal bowel left behind, those patients can get recurrent disease, and actually they do quite often. So certainly an unmet need is we don't have a cure for Crohn's disease. Now, having said that, we've made a lot of great strides in managing patients, beginning with drugs called the Tnf Inhibitors, which were introduced in 1998. Prior to that time, we had limited therapy that was marginally effective. Corticosteroids were used most often in patients who had severe disease, and that would work short-term but would not be an effective long-term drug. We then used drugs called immunomodulators, which were effective, but they had some problems associated with it as well. So the unmet need really, Neal, is to develop products that will suppress the inflammation, allow the underlying mucosa or lining of the intestine to heal, and most importantly, get the patient back to a normal life. So what we know about TNF inhibitors, which has become the biologic standard of care since they were introduced in 1998, we know that they help a large percentage of patients, and some would say perhaps up to 80% of patients will respond to TNF inhibitors. Two problems, though, Neal. 20% will not. So they need something different. They need a drug that affects the inflammatory response differently than by blocking tumor necrosis factor alpha. The other problem is not everybody that's treated with and responds to TNF inhibitors will stay in remission. So we know from the inflammatory cascade, as we call it, there are many different ways for inflammation to occur. So the unmet need is finding these targets, if you will, and then blocking them. And there are basically two ways to deal with this. You can either block a cytokine which is producing inflammation, or you can increase the production of a cytokine that is anti-inflammatory. So those are the two approaches. But there's a lot of room for improvement, as great as the TNF inhibitors have been. And then what came to market a couple of years ago is a different mechanism of action, something that is called an anti-Integrin, and that's called vedolizumab, or Entyvio is the trade name. So that gave us another option. What we hope to see later this year is yet another option, a drug called Stelara, or ustekinumab, which works differently. And we're hoping that by providing this to our patients, that we will give them yet one more option, one more pathway to block to manage their inflammatory process.
How much does diet play a role, and is this something that the patient can make a major part of their management, or is it negligible due to the nature of the disease?
Well, Neal, I'll answer that by saying what I would tell most of my patients, and I think diet is very individual. I think each Crohn's disease patient must be managed as one specific individual. And what I would tell patients is if they found something in their diet that was irritating or caused them to have symptoms, for example, dairy products or spicy foods or whatever, then they would have to avoid those if they wanted to stay well. But as primary management, diet alone, although it can be helpful in a general way, it usually is not going to allow the underlying mucosa of the bowel to heal and get that patient back to a normal life.
A misdiagnosis, someone thinking or being told that they've got another condition that looks like Crohn's, they're being treated and maybe managing at home for what they think is another thing, but it turns out to be Crohn's. How much trouble is a person in who's been treating one thing based on a misdiagnosis when they actually have Crohn's?
Well, that's a good question, Neal. And what we have learned in managing patients with inflammatory bowel disease in general and Crohn's disease in particular is they may go months and months and even years with symptoms that are inadequately treated because they have not been appropriately diagnosed. There are patients who are misdiagnosed with irritable bowel syndrome, which is a very, very common condition that can produce symptoms that are similar or maybe similar to Crohn's disease. And perhaps they had some testing done that was not diagnostic for Crohn's disease, so they were managed with irritable bowel type therapy. And when that happens, Neal, if you have ongoing inflammation, what we really worry about with Crohn's disease is this inflammation may progress, lead to scarring. It can even lead to perforation of the bowel, the need for emergency surgery. So that's why it's so terribly important to make an accurate and specific diagnosis as soon as the patient seeks medical attention. So we need to be all over these patients and make sure they get appropriate testing so that we can identify those who should have more specific therapy for Crohn's disease.
Talk briefly about the recent phase 3 study and those findings that affect Crohn's disease. What, in your opinion, do you think is the one finding that is just going to, revolutionize Crohn's disease treatment and management going forward?
Well, the study that will be published later this year, and hopefully the drug will be approved, is a drug called ustekinumab or Stelara. And in the phase 3 study that was just done, in patients who had failed Tnf inhibitors, and that's our most difficult population to treat, we found that over a third of those patients at week 6 had experienced a dramatic improvement in their symptoms. In patients who had failed conventional therapy but had not failed Tnf inhibitors, it was over half. And that's an important number. We also found that the response occurred very quickly. Equally important, the safety was very, very good. And then when those patients were treated with maintenance therapy, well over half of them were in remission at the end of a year. And again, with an excellent safety profile. So this is a drug that's got a very important role, and we hope to be using it later this year.
You've been listening to Health Professional Radio. I'm your host, Neal Howard, talking with Dr. John Popp. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm, and you can subscribe to this podcast on iTunes.